actually lupus. So I hope you'll allow me to favor you with some wolf jokes. Knock, knock. Who's there? Howl. Howl who? How will you know unless you open the door? And have you heard about the wolf in sheep's clothing? What do you call it? You call it wolf. WOOLF. Wolf. Hello everybody, Dr. Ryan here. Hope you and your folks and your family at home are well. Today we are addressing systemic lupus erythematosus, SLE. I encourage you to subscribe to my channel so you don't miss any exciting content coming up. Today's talk, guys, we're going to be outlining lupus in terms of introduction and our cardinal headings, etiology, why it happens, patient presentation, how it happens, together with pathogenesis, looking at a plausible differential diagnosis for that presentation, looking at diagnostic evaluation and investigative workup, treatment and management, prognosis and complications, and then we're going to talk about the key points to take home. We're going to close with scripture. God bless you. Thank you so much for joining me today. I truly appreciate your friendship on my channel. Let's get going, guys. We got a young 32-year-old woman with a long-standing diagnosis of systemic lupus erythematosus. Is evaluated by her rheumatologist as routine follow-up. Now, a new cardiac murmur is heard and an echocardiogram is ordered. She's feeling relatively well, has no fevers, no weight loss, no pre-existing cardiac disease. Okay, a vegetation on the mitral valve is demonstrated. Which of the following statements is true? A, blood culture is unlikely to be positive. B, glucocorticoid therapy has been proven to lead to improvement in this condition. C, pericarditis frequently present concomitantly. D, the lesion has a low risk of embolization. E, the patient has been surreptitiously using injection drugs. Let's talk, guys. So lupus or systemic lupus erythematosus, the wolf or SLE, is a chronic episodic multisystemic inflammatory disease of unknown etiology. Nobody knows why it happens, and is characterized by three things: B cell hyperreactivity, complement activation, and T cell defects. It can present with a multitude of signs and symptoms which mimic many other diseases. Lupus is the great mimicker. Okay, therefore the diagnosis may sometimes be delayed. It's usually a clinical diagnosis which is merely supported by laboratory abnormalities. The characteristic lab finding is that of positive anti-nuclear antibodies, ANA. Complex genetic traits and environmental factors play a role in causing eventually the end result of immune dysregulation. That's the big buzzword. 90% of cases occur in females, right? Let's look at etiology, epidemiology, and risk factors. So the main problem is that there's autoantibodies directed against nuclear components, including DNA, which mediate the formation of immune complexes, right? Circulating immune complexes then become deposited in vascular walls, and complement activation at these vessel walls further causes inflammation of tissue. The etiology, like we said, nobody really knows. There is a probable strong genetic contribution in that 10% of patients with lupus do have a first-degree relative who also has lupus. A lupus-like syndrome may occur due to certain drugs, including procainamide, isoniazid, minocycline, hydralazine, and there you get the antihistone antibody being positive. Peak onset occurs amongst teenagers and during middle age. Upwards of 20% of cases actually begin early on in childhood. Prevalence approximately 1 in 2,000, so not all that uncommon. There's a greater incidence of prevalence amongst the population that are African Americans, Afro-Caribbeans, and some Native American tribes. Women are affected a whopping 9 times more frequently than men, but also do not miss the diagnosis of lupus in the male. That is a major cause of medical legal cases, right? Lupus being missed in the male, even though we know it's probably more common among females. Ultraviolet B or UVB light in pregnancy can induce flares. Renal involvement is the major cause of morbidity, and we'll be talking about that. Increased susceptibility to infections due to both active disease and immunosuppression. Okay, so the pathogenesis in SLE has been postulated. A couple of predisposing factors here: the genetic component, especially with deficiencies of C1, C2, C1q, C2, C4, right? You got, and these affect antigen presentation of persistence, phagocytosis of immune complexes associated with HLA, DRB1 genetic haplotype. enhancement of innate immunity, including production of interferons, alteration of adaptive immunity and B and T cell signaling. All of this has to do with the genetic component. Then genes for lupus nephritis have been discovered. Factors in the environment and microenvironment like UV light, smoking, crystalline silica, maybe EBV infection, and then epigenetics as well, right? So you've got these predisposing factors, number one, and then this instigates an abnormal immune response with abnormal antigen processing and B and T cell reactivity, and eventually have the formation of, we have, defective suppressive networks, and that leads to autoantibodies, formation of immune complexes, which then gives rise to widespread inflammation, which underpins the physical manifestations of disease. You get rash, nephritis, arthritis, leukopenia, CNS disease, carditis, clotting, etc., inducing chronic inflammation, chronic oxidation, lipid peroxidation of your cell membranes, giving rise to damage, which manifests as renal failure, atherosclerosis, pulmonary fibrosis, stroke, etc. So if you remember the mnemonic 4 rashes, the 4 rashes being your oral ulcers, your photosensitivity, your malar rash, and of course you got the chronic cutaneous lupus, right, which is the discoid lesions and the chilblain lupus, etc. And RASHES, R is for renal manifestations, lupus nephritis, A is for arthritis, arthralgia, S serositis in the way of pericarditis and pleural effusion, pleuritis, E in the way of excitation of CNS disease, and S is serology for rashes. That's the easy way to remember it, right? Alrighty, guys, diagnostic criteria is to follow on a subsequent slide, but clinical features include the malar or the so-called butterfly rash, right? It happens to spare the nasolabial folds, right? That's a characteristic thing, versus rosacea, which is going to involve the nasolabial folds. We've got a discoid, which is a red, raised, scaly rash. We've got photosensitivity, which is skin rash in response to light, and oral ulcers, okay? Then we've got symmetric migratory arthritis, particularly of the fingers, hands, wrists, and knees. Serositis, speaking to pruritus, pericarditis, renal disorder, and the way of persistent proteinuria above 0.5 gram per day, or you got cellular CAS. So you got proteinuria, sometimes hemoproteinuria. Neurological disorders in the way of seizures and psychosis, right? Hematologically speaking, we have hemolytic anemia together with leukopenia and lymphopenia. So you want to do your full blood count for the differential. You can also get thrombocytopenia. Immunological disorder, your serology will show you anti-nuclear factor being positive together with other extractable nuclear antigens, your anti-double-stranded DNA, anti-Smith, anti-phospholipid antibodies, which is your your lupus anticoagulant, your beta-2-glycoprotein, your cardiolipin, and you got a positive ANA. So remember 4 rashes, right? Malar and discoid rash, oral ulcers, photosensitivity, you got the acute and cutaneous lupus, renal affectation R, A for arthritis or arthralgia, S for serositis, H for hematological problems, E for excitation, speaking to CNS disease, and S for serology. 4 rashes, easy guys. So this is just looking at the relative prevalence of each of these clinical manifestations that we just discussed. So of course constitutional symptoms are there, right? 95% of the time. This is spanning the entire course of disease, right? So systemic things like fatigue, malaise, fever, anorexia, weight loss. Musculoskeletal, 95% of the time. Arthralgias, myalgias, most common, followed by polyarthritis, hand deformity, Jacquard's arthropathy, myopathy or myositis with weakness, ischemic necrosis of bone on account of steroids, which is the treatment or the disease process itself. Cutaneous manifestations, 80% of the time, with photosensitivity coming up most common, followed by your malar rash, which spares the nasolabial folds, your oral ulcers, your alopecia, discoid rash, vasculitis, and then other cutaneous manifestations. Hematologically, there's 85% of the time you may have a blood dyscrasia or a blood abnormality, or anemia of chronic disease being the most common at 70%, followed by leukopenia, then lymphopenia, thrombocytopenia, lymphadenopathy, splenomegaly, hemolysis, right? Neurologically speaking, 60% of the time, the most common manifestation is cognitive disorder, followed by mood disorder, depression, headaches, seizures, very important, mono or polyneuropathy, then less common stroke, TIA, acute confusional state or movement disorder, aseptic meningitis, myelopathy. Cardiopulmonary, 60% of the time, probably most common serositis, guys, pleuritis, pericarditis, followed by myocarditis, endocarditis, and then others somewhat less common. Watch out for acute respiratory distress syndrome and pulmonary hemorrhage, pulmonary hypertension. Renal, 30 to 50% of the time, but renal disease is the main cause of morbidity in lupus, okay? You're looking for a proteinuria above 500 milligram per 24 hours and cellular CAS, nephrotic syndrome, and then, of course, end-stage renal disease. GI manifestations, 40% of the time, mostly non-specific in the way of nausea, mild pain, diarrhea. We also get transaminitis and vasculitis. Thrombosis, 15% of the time, venous and arterial, associated usually with antiphospholipid antibody syndrome in the context of lupus. Then ocular manifestations being sick Zika syndrome, conjunctivitis, epiglottitis, and vasculitic lesions. This is a beautiful male rash of lupus, the butterfly rash. Note that it bears the nasolabial folds. Thank you so much. If it involves the nasolabial folds, you're probably dealing with rosacea. This is Jacques arthropathy, which is non-deformative polyarthritis of the small joints of the hands. Okay. And as you can see, by definition, it's a non-deformative reducible, arthropathy. Okay, here's a nice method of examining the patient for lupus. So you've got to be systematic, guys. You go according to your headings. This is taken from Talley and O Connor. So in general, just inspect for the cushion-guide appearance, usually on the back of steroid use, right? Weight and the mental state, because these patients can be confused as well. It's one of the neurological manifestations, like we said. In the hands, you look for a rash of vasculitis, right? So you look for nail fold infarcts. You look for rash, you look for arthropathy, right? In the arms, look for lividoreticularis, the so-called net-like formation, or the net-like rash or meshwork, if you like, purpura and proximal myopathy, which can be due to active disease or steroids. In the head, you want to look for alopecia with or without scarring. Lupus hairs. In the eyes, look for red eye sternitis or cytoid lesions with the fundoscope. Mouth, look for ulcers and infection. Then look for the malar rash, the butterfly rash, cranial neuropathies, and cervical latinopathy. In the chest, you examine for pericarditis, which speaks to serositis, right? So pericardial friction rub, other stigmata of pericarditis. Respiratory system, look for pleural effusion, pleurisy, pulmonic fibrosis, collapse, or infection. In the abdomen, check for hepatosplenomegaly and tenderness. In the hips, spring those hips and check for aseptic necrosis, right, which is due to lupus or due to steroids. In the legs, you check the feet for red soles and small joints and a virus. Check for a rash, especially livido. And ulcers over the malleoli could point to antiphospholipid antibody syndrome. Check for proximal weakness, which speaks to a myopathic process, neuropathy, mononeuritis, multiplex, cerebellar ataxia, hemiplegia. You want to also check the urinalysis for proteinuria. Sometimes you get a nephrotic picture, sometimes nephrotic. Sometimes you just have active red cell sediment or active sediment. Blood pressure, being hypertension, and temperature chart, right? Guys, what's the differential diagnosis for lupus? We said lupus is a great mimicker. A lot of things can look like, smell like lupus, right? Rheumatoid arthritis is close seropositive friend, right? Remember, the other seropositive manifestations are polymyositis, SLE, Sjogren's, rheumatoid arthritis, right? So all of those. Progressive systemic sclerosis as well, dermatopolymyositis, also seropositive disease, acute rheumatic fever, serum sickness, Behçet's disease, look for those oral and genital ulcers, right? Polyarthritis nodosa, infections, a whole lot of infections, HIV, arthropathy, syphilis, parvovirus, B19, rubella, Epstein-Barr, toxoplasmosis, TB, leprosy, schistosomiasis, leishmaniasis, sarcoidosis, porphyria, lymphoma. All right, guys. Now, you suspect your patient has lupus. How are you going to investigate them? Nice to ask. Always take a careful history and physical exam. Then we've got the SLicc criteria, which we're going to talk about just now, which has a more than 95% specificity and sensitivity for the diagnosis. Initial testing, do a full blood count with differential and a smear, urea and electrolytes, liver function test, urinalysis, look for active urine sediment, look for hemoproteinuria, do a 24-hour urine collection for protein creatinine clearance, or you're going to do a spot urine for protein creatinine ratio. Very important, guys. You must test. This is the entry criteria as per the ACR-EULAR criteria. You want to do an anti-nuclear factor level. If the ANA is positive, you can look for extractable nuclear antigens, your anti-double-stranded DNA, anti-Smith, anti-Rho and La, which speaks to Sjogren's, anti-ribonuclear proteins. It's indicated. Anti-U1 RMP means you probably have mixed connective tissue disease. And of course, the key thing is that you're going to consume complement in lupus, right? So your C3, C4 likely to be low, represents an active disease or a flare of the disease. Now, if either your rapid plasma reagent or your partial thromboplastin time is abnormal, you want to test for antiphospholipid antibodies. Test your lupus anticoagulant, your beta-2-glycoprotein, your anticardiolipin. Anemia with elevated retic count may indicate the presence of hemolytic anemia. So your LDH will be up, speaking to hemolysis. Your Coombs may be positive, speaking to this being an autoimmune process, right? You may have reticulocytes, right, on your smear as well. And your elevated retic count. ESR and CRP, and your haptoglobin will be low. Chest X-ray and echo may be indicated if there is cardiac involvement. Renal biopsy is sometimes indicated. Pregnancy test is good in women of childbearing age because some of the drugs that we use are teratogenic, right? And if you got, antiphospholipid antibody syndrome, right, The antibodies can cross if you've got anti-Ro, and that can cause congenital heart block in the child. HIV testing, hepatitis screening, sputa for gene expert, because you want to rule out these conditions if you're going to immunosuppress the patient, especially with monoclonal antibodies, all right? So here we're just having a quick squiz at the autoantibodies we have present in lupus. We already alluded to some of them. Anti-nuclear antibodies, the prevalence is 98%, right? And you must recognize the pattern, right? If it's speckled or homogeneous, and the titer as well, right? Anti-double-stranded DNA, 70% prevalence, okay. High titers, SLE specific, very specific, right? Then you got your anti-Smith, and 25% of the time you got your anti-U1 RMP, anti-Ro, anti-last week Sjogren syndrome, anti-histone in the context of drug-induced lupus, anti-phospholipid antibody. We spoke to beta-glycoprotein, we spoke to anti-cardiolipin and lupus anticoagulant. Righty. Now, let's look at the classification of lupus nephritis, right? So there's basically 5 classes. We look at class 1 refers to minimal mesangial lupus nephritis. We have normal glomeruli by light microscopy, but you got mesangial immune deposits by immunofluorescence. That's how you pick it, with immunofluorescence. Stage 2 is mesangial proliferative lupus nephritis. Stage 3 is focal lupus nephritis, divided into A or C based on whether it's acute, active or chronic, right? Stage 4 is diffuse lupus nephritis, once again A or C based on acute or chronic. And here we have active or inactive, diffuse segmental or global endo or extracapillary glomerulonephritis involving more than 50% of all the glomeruli, hence the term diffuse, typically with diffuse subendothelial immune deposits with or without mesangial alterations. Class 5 is membranous lupus nephritis, where you have global or segmental or subepithelial immune deposits or their morphological sequelae by light microscopy or immunofluorescence or electron microscopy with or without mesangial alterations. Right? Stage 6 is terrible advanced systemic lupus nephritis, burnt out. We're not going to do much about that. More than 90% of the glomeruli are globally sclerosed without residual activity. This patient should be obviously considered for renal transplant and or dialysis. Okay. Now, looking at the SLIC criteria, very slick and nice. Ha 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 ha. Okay, here we're talking about the SLIC stands for Systemic Lupus International Collaborating Clinic Criteria for Classification of SLE. We split them into 2 flavors. First flavor is clinical manifestation, second flavor, immunological manifestation. Let's talk about immune manifestation first. Now, remember that you have the presence of any 4 criteria, at least 1 from each category, but you have at least 4 criteria, qualifies the patient to be classified as lupus with a 93% specificity and 92% sensitivity. That's how you interpret this from the get-go. Immunologically speaking, you must have an ANA, which is greater than the reference negative value. But in the ACR-EULA criteria, the titer of your ANA must be at least 1:80, right? And you got the anti-double-stranded DNA, which is greater than the reference level, if by ELISA, twice the reference level in terms of your anti-double-stranded DNA. Then other extractable nuclear antigens, anti-Smith being positive, anti-phospholipid, where you speak about the lupus anticoagulant, the beta-2-glycoprotein, the anticardiolipin. You got a low serum complement, C3 and C4, or C3 or C4, and a positive direct Coombs test speaking to autoimmune process, okay? Usually hemolysis, right? So you have, that, and then you have a few clinical manifestations in the skin. You can have acute or subacute cutaneous lupus being the photosensitivity, the malar rash, the maculopapular rash, the bullous lesions, and the chronic cutaneous form in the way of discoid lupus, paniculitis, lichen planus-like or hypertrophic verrucous or chilblain lupus, right? Then you also the ulcers, oral or nasal ulcers, non-scarring alopecia, synovitis involving at least 2 joints or more joints, more than 2 joints, serositis, speaking to pruritus, pericarditis. In terms of renal, we spoke to protein creatinine ratio above 0.5 gram per 24 hours, right? And red cell cast, so active urine sediment, and you may have to do a biopsy to ascertain the stage. We spoke about the 6 stages. Neurologically speaking, the patient has seizures, psychosis, mononeuritis, myelitis with spinal cord involvement, peripheral or cranial neuropathies, acute confusional state, hemolytic anemia. So HB is low, your tick count is up, your haptoglobin is low, your LDH is up, and your Coombs may be positive, and you get a higher ticks, right? That speaks to hemolytic anemia. Leukopenia less than 4,000 per microliter or lymphopenia less than 1,000. You must do a differential count. Otherwise, you're going to miss that. Thrombocytopenia less than 100. Okay. ACR-EULA, same story, different technique, different way of assessing it, right? So there, the entry criteria is at least the ANA being positive at a titer of 1:80. That's obligatory. Followed by additive weighted criteria in 7 clinical and 3 immunological domains. A cumulative score of over 10 classifies you as SLE. Right, so this differs from the SLIC, where we said we have at least 1 immunological, 1 clinical criteria, compositely more than 4, gives you at least a 93% sensitivity and 97% specificity for SLE. ACR EULAR, similar but slightly different, okay? And here we're talking about constitutional things like fever, then hematological, leukopenia, thrombocytopenia, autoimmune hemolytic anemia. We already covered these guys. Neuropsychiatric, mucocutaneous, serosal, musculoskeletal, renal, and of course we speak about the domain being antiphospholipid complement and SLE specific autoantibodies. We touched on this. Okay, guys, this is just to mention the auto antibodies and antiphospholipid antibody syndrome. So the mnemonic is LA-BC, anti-lupus anticoagulant. LA, B is beta-glycoprotein, C is cardiolipin. Guys, how are we going to manage lupus? So lupus, as we know, follows a chronic course with exacerbations and remissions. The underpinning principle of therapy is to treat disease manifestations and not just your serology. Treat your disease manifestations. Avoid sun exposure, use sunscreens. Non-steroidals and antimalarials like hydroxychloroquine for arthritis, sinusitis, or rash. Serious disease is treated with steroids and immunosuppressant drugs for steroid-sparing effect. Daily prednisone, if it's not life-threatening, daily prednisone at least 0.5 milligram per kg, at least 30 milligram or less. But if it's life-threatening manifestations like cerebritis, glomerulonephritis, we can pulse our steroids. So solimedrol is usually what we go for, right? IV steroids 1 to 2 milligram per kg per day. Then we put the patient onto oral prednisone and taper off that dose, 1 to 2 milligram per kg. Immunosuppressive drugs like cyclophosphamide, azathioprine, mycophenolate mofetil, methotrexate, cyclosporin may be used in cases of life-threatening disease and, of course, with steroid-sparing effect. Okay, intravenous immunoglobulin may be used for acute thrombocytopenia or acute hemolytic anemia. Warfarin for anticoagulation in cases of antiphospholipid antibody syndrome. Important to note that we don't use the newer oral anticoagulants in the context of antiphospholipid antibody syndrome. Warfarin is the go-to guy. An anti-CD20 monoclonal antibody in the way of rituximab for refractory disease, dialysis and renal transplantation for renal failure. Other experimental therapies, well, not really experimental, we use it now. TNF blockade, which is infliximab, tocilizumab, pegol, adalimumab, golimumab, etanercept, anti-CD40 ligand antibody, right? Here's a beautiful algorithmic approach to managing SLE. So if you've got a symptom complex which suggests SLE looks like, smells like lupus, do your confirmatory lab test, your ANA, your extractable nuclear antigens, your full blood count with differential, your platelets, your urine analysis. And then, if all tests are normal and the symptoms subside, you can bet your bottom dollar this is probably not SLE. But if all the tests are normal and the symptoms persist, just repeat the ANA, the anti-double stranded DNA, the anti-RO. If it's negative, it's not SLE. If it's positive, then you progress to the right-hand side of the algorithm. If your ANA is positive and you've got possible SLE being less than 4 SLIC criteria, then you want to treat. If it's definite SLE being more than 4 SLIC criteria in either immunological clinical domains, you treat. Then the next part of call is to ask yourself, are you dealing with life-threatening disease or is it non-life-threatening? If it's not life-threatening, the quality of life is acceptable, conservative management. But if it's non-life-threatening, quality of life not acceptable, conservative treatment plus low-dose steroids, and you consider your monoclonal antibodies. But if you're dealing with life or organ-threatening disease, right, your cerebritis, right, your autoimmune hemolysis, your glomerulonephritis, your serositis, right? You go high-dose glucocorticoids, usually with addition of a second agent, right? So in lupus nephritis, the go-to guy is mycophenolate mofetil. Plus, you can use a calcineurin inhibitor like tacrolimus, maybe used instead of MMF alone or cyclophosphamide. You can go cyclophosphamide, but you don't want to exceed 6 months of treatment. It's very, very toxic. We'll talk about it. You can go low or high dose and or MMF, right? And then you, after the response, you're going to stop cyclophosphamide and you maintain with either mycophenolate mofetil or azathioprine. If there's no response, consider your monoclonal antibodies. If there is a response, taper the dose of all your agents, especially glucocorticoids. So glucocorticoids are not innocuous drugs, guys. They cause a whole plethora of side effects. They cause posterior subcapsular cataract. They cause gastric ulcer, suppression of your HPA axis, hypertension, hyperglycemia, ischemic necrosis of the femoral head. They cause neutropenia and they cause psychosis. Okay, guys, just to touch on a couple of the medications. Sorry, the slide is a bit busy, but we're looking at the different treatment options, or we have in terms of medical management of SLE. So non-steroidal salicylates, right, for conservative management of non-life-threatening disease, right? But watch out for the usual complications, right? So non-steroidal is not good in the context of renal disease because they cause afferent arteriolar vasoconstriction, diminish your GFR, they cause peptic ulcer. Watch out for that. Topical glucocorticoid is relatively safe, especially for dermatological issues, right? Topical sunscreens are advisable as well. Antimalarials like hydroxychloroquine, the dose 200 to 400 milligrams at least 5 times, it's daily for 5 days a week, right? It's contraindicated with QT prolonging drugs. The important thing to watch out for is retinal damage. So it causes bull's eye maculopathy. Agranulocytosis has been associated with aplastic anemia, peripheral neuropathy, thrombocytopenia. Right, then we can go methotrexate is the anchor drug in rheumatoid arthritis. We hardly use it in the context earlier of lupus, but the dose is 10 to 25 milligrams once a week, co-administered with folic acid. Remember, it's known to cause anemia, myelosuppression, leukopenia, thrombocytopenia, hepatotoxicity, nephro and neurotoxic, pulmonic fibrosis, pneumonitis, seizures, etc. Glucocorticoids, as we already touched on. So usually you go prednisone or prednisolone, 0.5 to 1 milligram per kg per day. If it's severe disease, you want to probably go methylprednisolone, which is solumedrol. You pulse therapy for at least 3 to 5 days, usually 3 days, 0.5 to 1 gram daily IV, right? Watch out, we already spoke about the adverse effects of steroids, not innocuous drugs at all. Cyclophosphamide is a good guy to use, but it's a dangerous guy to use. You can go low dose or high dose. The low dose, right, is 500 milligram every 2 weeks for 6 doses, then maintain with MMF or AZA. But the high dose is 7 to 25 milligram per kg every month for 6 months, and consider Mesnap because you don't want to cause hemorrhagic cystitis, right? That's one of the dreaded adverse effects, right? In that, it obviously can predispose to infection, myelosuppression, leukopenia, anemia, thrombocytopenia, hemorrhagic cystitis, less with the IV formulation, more with the oral formulation, can cause carcinoma of the bladder, alopecia, nausea, diarrhea, malignancy, ovarian testicular failure. So if you've got a female patient who wants to go and preserve her ova, good idea before you start cyclophosphamide, right? Then mycophenolate mofetil, the dose is 2 to 3 grams per day, oral given BD for induction therapy, and then 1 to 2 grams per day given total BD for maintenance therapy. Maximum 1 gram BD if your creatinine clearance is below 25 milliliters per minute. Start treatment with 0.5, which is 500 milligrams BD. If used concomitantly with a calcineurin inhibitor, the target dose is 1 gram BD, right? Also known to cause infection, leukopenia, hematological manifestations as a side effect, GI symptoms, hypokalemia, insomnia, edema, elevated liver enzymes. Watch out for that. Azathioprine, the dose is 2 to 3 milligram per kg per day for induction per us, and then 1 to 2 milligram per kg for maintenance. Decreased frequency of dose if creatinine clearance drops below 50. It causes cytopenias, it causes bone marrow suppression, it causes pancreatitis, hepatotoxicity, flu-like illness. Rituximab is the anti-CD20, anti-B-cell monoclonal antibody known to cause infection. You must rule out hepatitis and TB before you start this, right? It can cause local infusion reactions, headache, arrhythmias, allergic responses. Then tacrolimus is a calcineurin inhibitor. It increases risk for QT prolongation. Watch out. It can cause infection, nephrotoxicity, and neurotoxicity, all right? Okay, guys, what's the prognosis and complications? So complications of lupus can include Jacob's arthropathy. For this, you want to do, it can cause tendon disease and rupture, so watch out for that. Avascular necrosis of the hip and other joints on account of chronic steroid use, especially shoulder and knee. Cause thrombosis, usually in the context of antiphospholipid antibody syndrome, and cause vasculitis. Glomerulonephritis we spoke about, especially in the 6-way staging of lupus nephritis. Pericarditis, which is pericarditis and pleuritis together called serositis. Pneumonitis and complications of non-steroidals and steroids, and we have gastritis, GI bleeding, chronic renal failure, right? So more than 90% of patients are alive at 10 years post-diagnosis, and 70% survive up to 20 years. What are the indicators of poor prognosis? Hypertension, nephritic syndrome, elevated creatinine, anemia, antiphospholipid antibody syndrome. The most common cause of death during the initial decade post-diagnosis, infection. Half of the fatal infections involve opportunistic organisms, the likes of Pneumocystis carinii and Candida. And of course, people die also after infection. The most other common causes of death: renal failure, thromboembolic disease, cardiovascular disease, right? Coming back to our clinical case, we have this young lady who's known with SLE, now presenting with a cardiac murmur. She has no fever, weight loss, or pre-existing cardiac disease, so you can't implicate rheumatic fever, infective endocarditis, and there's a vegetation on the mitral valve. Which of the following statements is true? Most likely blood cultures are unlikely to be positive because this is Lipman-Sachs endocarditis. Remember, SLE causes LSE. SLE causes LSE. Systemic lupus erythematosus causes Lipman-Sachs endocarditis, and this is a fibrinous endocarditis that can lead to valvular insufficiency, most often mitral aortic embolism. Because Lipman-Sachs endocarditis is a culture negative endocarditis by definition, it is not thought to be due to microbial infection. Blood culture is unlikely to be positive. Guys, takeaway points. Here we go. SLE, systemic lupus erythematosus, is a chronic multisystemic inflammatory disorder of autoimmune etiology occurring predominantly among young women. In fact, the female to male ratio is a whopping 9:1. Common manifestations may include arthralgias and arthritis, malar and other rashes, pruritus, pericarditis, renal or CNS involvement, hematological cytopenias. But remember the mnemonic for rashes: malar and discoid rash, oral ulcers, photosensitivity. Rashes, R is for renal, so hemoproteinuria or proteinuria above 0.5 gram per 24 hours. Right? A is for arthralgia, arthritis. S is for serositis, being pleuropericarditis. H, hematological in the way of cytopenia. So you get lymphopenia, leukopenia, thrombocytopenia, autoimmune hemolysis. E is for excitation, speaking to CNS disease. S is serology, with your ANF being positive, anti-double-stranded DNA being positive, the other extractable nuclear antigens, anti-Smith being positive. You may have positive Sjogren's, you may have antiphospholipid antibody syndrome. Right, so then SLICC criteria means you have at least one immunological and at one clinical criteria, with the composite criteria being more than 4, gives you the diagnosis. At least you should have a positive titer, at least 1:80 or more. Diagnosis requires clinical and serological criteria, because the SLICC criteria, the ACR-ULA criteria. Treatment of severe ongoing active disease requires corticosteroids, most often antimalarials like hydroxychloroquine, and sometimes immunosuppressants. Okay, my friends, the Lord Jesus Christ told us in Matthew 20, verse 26 to 28, whoever wants to become great among you must first be your servant. Whoever wants to be first must be your slave. Just as the Son of Man came not to be served, but to serve, and gave himself as a ransom for many. In the Bible, it says the first will be last and the last will be first. Just like how water always flows to the lowest level. So, if you want to be great, you have to come down. Philippians 2:5 says, your attitude should be that of Christ Jesus, who being in the very nature God, considered equality with God not something to be grasped, but made himself nothing, taking the form of a servant, being made in human likeness, being found in appearance as a man, he became obedient to death. Where? Death even on the cross. Therefore God has exalted him to the highest place, and has given him the name that is above every other name, that at the mere mention of the name of Jesus, every knee shall bow, every tongue confess that Jesus Christ is Lord. If you want to be great, if you want to be a leader, you must first be a servant. That is the order of it. God bless you guys. Here's my references. If you enjoyed this content, I encourage you to subscribe to my channel, like and share this video. Thank you so much. You can catch me on Facebook. Just search for Internal Medicine Algorithms and Mnemonics. I'm also on TikTok and Instagram as well. We've got some exciting topics coming up. A comprehensive approach to anemia. I'm also going to be talking about acute meningitis. God bless you. Thanks for joining me. I will catch you soon.